Good evening, everybody, and thanks for joining us in our third orthopedic specialist session on going through different parts of the body with starting off with knees. We've gone through to the shoulders, and now we're going to do foot and ankle. I'm absolutely privileged to have Mr. Nima Heidari and Mr. Thomas Hester joining us today for our session this evening. I'm just going to share my screen with everybody, so welcome. To everyone who's just signing in here. Let me get my screen up. So, great. So today we're going to be looking at updates in heel pain and ankle instability. My name is Raghbir Khakha. I'm one of the team. I'm one of the knee surgeons working with orthopedic specialists, and I'll be hosting this evening's session. I'm one of many members of a huge team that look after all elements of limb problems. So we're ranging from maxillofacial issues through to shoulder, hip and knee, foot and ankle, and spine. We also have pain specialists on our team. So you can see there's quite a few people that are involved. And then a few of these faces will be familiar to you, who've already been sat on the panel for our educational evenings. And there are a few faces in there that will be joining us over the coming weeks. So thanks again for joining us today. This is where we work. It's our Harley Street Specialist Hospital, where we do a lot of our day case operating, and our more major procedures are done at the London Clinic. Many thanks to the London Clinic for their kind support in this event. I know a lot of you work closely with the London Clinic, and they've kindly helped support this evening, so many thanks to them. So this leads me on to our faculty this evening. As I said, very privileged to have both Mr. Nima Heidari and Tom Hester talking today. And we're going to be talking predominantly about ankle instability and heel pain. So firstly, Mr. Nima Heidari, he's a well-known and respected consultant out of the Royal London Hospital. As you may have come across, Royal London is one of the largest trauma centres and certainly one of the busiest in Europe, and his main area of expertise is foot and ankle surgery and limb reconstruction. He deals with all elements of foot and ankle problems, ranging from chronic arthritic conditions through to sports conditions. And he's also well known for his work in bone infection, for which he has done collaborated with international teams to write research, and he dictates how work is done in this field. So really glad to have him on the team. And Mr. Thomas Hester. Tom is a good friend of mine, and recently joined the team at Orthopedic Specialists. He's also a foot and ankle specialist, currently working at Lewisham, and soon to be coming across to King's College London. He, much like Nima, has got a real interest in foot and ankle surgery, all elements of foot and ankle, but also dealing with multiply injured people with trauma, limb reconstruction. He's got an interest in teaching and research, and he's going to be talking to you today with Nima, covering both heel pain and ankle instability. As part of the program, following on from this talk today, in 2 weeks from now, we'll have our next webinar, and we'll be joined by Mr. Tom Pollard and Tony Andrade. Tony Andrade is actually the president of the Hip Arthroscopy Society, and Tom Pollard is a well-known hip arthroscopy surgeon. And we're going to be looking at updates in hip joint preservation. So you'd be welcome to join us on the 1st of July at 6:30 p.m. For today's talk, there's going to be a questionnaire that follows. And if you kindly fill out the questionnaire, we will send out a certificate with 2 CPD points awarded for tonight, which are accredited by the Royal College of Surgeons. If you want to hear more about the events that we're having, please follow us on LinkedIn and just type in Orthopedic Specialists. These are our Twitter handles for any further updates. And if we frequently welcome and host people to come and visit and watch us perform procedures, sit in on clinics, or simply just discuss cases. Feel free to contact us on this telephone number, email address. And this talk will be uploaded onto our Orthopedic Specialist page on YouTube. So if you don't get to listen to all of it, feel free to visit that site. So thanks very much. I'm going to stop sharing my screen. I'm going to hand over to Mr. Nima Heidari. Thanks, Nima.
Brilliant. Rags, thank you very much, and welcome to all of our colleagues who've joined us. I'm going to start sharing my screen. So I'm going to talk to you a little bit about ankle sprains and ankle instability. My name is Nima Heidari. As Mr. Khakha said, I'm a foot and ankle surgeon and limb recon surgeon. I work at the Harley Street Specialist Hospital, and again, thanks to the London Clinic where I do my major procedures, who are supporting us in this event. So, ankle instability. This is a kind of presentation you get. Typical, let's say a 30-year-old chap was playing basketball with his friends, falls over, twists his ankle, and comes to your clinic like this. You can see that there is swelling on the outer side of the ankle and some bruising. Typical mechanism. Here we are, video of a basketball player. You can see just rolling over the ankle and landing awkwardly. It is actually, ankle sprains are one of the most common athletic injuries. Basketball is the perfect way to cause an injury to your ankle, and in the US, they account for 10% of all emergency room visits. A substantial proportion of these injuries do end up being chronic, and what I mean by that is chronicity, is that the length of time that these symptoms come to cause bother for the individual. It seems to be more common in men, and actually the peak incidence is in the relatively young. The way I approach these is with a history. You always need to get the story of exactly what has happened. That gives you an idea about the energy that's been imparted to the ankle and the likelihood of more complex injury rather than a simple ankle sprain. Once we've got that out of the way, then we need to think about examining the ankle, and it always starts by looking. You can look to see where the bruising is. You can see in this picture there is bruising on the medial side of the ankle. That may denote that there is an injury to the medial structures, or a sprained ligament, or some of the other problems. And in fact, in some circumstances, if the ankle injury is a few days old and the patient has been elevating it, the bruising can actually track from the site of injury to elsewhere. Is also to look at the other parts of the foot and the ankle. You can see that the bruising here is mostly across the dorsum of the foot, and it's on the plantar aspect of the foot. The story for this lady is much the same. She fell and twisted her foot and ankle, but in fact what she has sustained here is a midfoot fracture, and the ecchymosis, the plantar ecchymosis, the bruising on the sole of the foot, is pathognomonic of that. So it's very important to look and if something doesn't look quite right, examine further, investigate further. The next thing is to feel, and for that, which areas do you feel? Here is some lovely anatomical slides to demonstrate that this is the, now colored in green, are the two bands of the ATFL. The anterior talofibular ligament, the ligament that seems to be injured most commonly in these. That's the calcaneofibular ligament and the posterior talofibular ligament, the three components of the lateral ligament complex. The feeling starts by looking at by palpating the specific sites, the anterior talar dome, the lateral ligaments. You can see how the peroneal tendons also are standing to attention beneath the examiner's finger there, so they're actually quite close by, and the CFL, the calcaneofibular ligament, is slightly more posterior than that. Palpating the base of the fifth metatarsal, it's not unusual to injure and get a fracture of the base of the fifth metatarsal at the same time as having an ankle sprain. Also examining the medial ligaments, both the inferior and the superior attachments, and also the spring ligament, injury deeper to the instep of the foot. The next thing is to move the foot and ankle, and this can either be static or dynamic. And I'll show you some special tests that are important to assess the lateral ligament. So here, if you look at the lateral malleolus, you can see how the skin gets sucked into the space which is created by drawing the talus out of the mortise. This is a positive anterior draw, and this is an individual that I operated on because he had long-standing instability and physiotherapy did not help him in the end. The other thing to recognize is that the medial ligament can also be injured. I'm not going to talk a great deal about that today, but look, in a similar way, you can have an anterior draw where the medial side is coming out of the ankle mortise. The next thing to do is to organize imaging. X-rays are very good to look at the bony anatomy, to look at the alignment of the foot and the ankle, and also to demonstrate presence of fractures. They must be weight-bearing if the patient is able to bear weight, because foot and ankle are weight-bearing structures, and they are the best way to x-ray them is through weight bearing. It's much more diagnostic. Ultrasound scan is a very good dynamic assessment, and it's good to guide injections, but it is very much dependent on the operator. So it has to be someone that you trust, or at least someone that you can communicate well with. The other standard is MRI scans. Very good to look at the soft tissues, the ligaments, demonstrate any occult fractures or injuries to the talar dome and the cartilaginous surfaces around the ankle. There are always some red flags that you need to be aware of. If the patient is unable to wear weight, if there is significant swelling, if there is significant deformity, and if things are actually deteriorating rather than getting better, that's really important. The other thing is that your clinical findings, if something doesn't look quite right, be prepared to investigate further. That's an important thing and you must heed it. Now, how do we think about the severity of ligament injuries? There are a number of different ways. You can either have a descriptive way of classifying the ligament injuries from grade 1, a little bit stretched, to grade 3, really badly torn. But sometimes these don't actually provide us with a good way to think about how to treat these injuries. So one of the ones that I favor slightly more is looking at both the mechanical and the functional side of the ankle with regards to stability. What we mean by mechanical instability is actually pathological joint laxity, where there are multiple ligaments that are injured and the ankle is very unstable in the mortise. The functional instability is the inability of the individual to control the ankle, either when they're standing or during gait or during sporting activities. And particularly if there is a combination of these two, then symptoms can become chronic. They can last long and they can become a problem over a prolonged period of time. The way to think about these recurrent instabilities, again, it comes to the mechanical insufficiency, which include things like either joint being too stiff or too lax, degenerative changes within the ankle, or synovial changes which are causing and mimicking symptoms of instability. The functional insufficiency are the things such as the impaired proprioception, impaired neuromuscular control, where the muscles don't quite do what you expect them to do. Postural control is poor, and actually there is a reduction in the strength of these muscular tendinous units because they're not being used in an anatomically and biomechanically advantageous way. Other reasons for prolonged symptoms are injuries that are associated with the ankle sprain and come along with it. Typical one are longitudinal split tears of the peroneal tendons, peroneal tendon pathology. As I said earlier on, you can see that the base of the fifth metatarsal here, you've got a little avulsion fracture, and this is another injury that needs to be picked up. One of the other things that we can find is neurapraxia, injury to the nerves around the ankle. You can see that the sensation to the foot and the ankle is supplied by a number of different nerves, the sural nerve and the superficial peroneal nerve. When the ankle is sprained and it moves beyond a certain limit, as well as stretching the ligaments, it also stretches the nerves that are around the ankle. The traction on these nerves can then cause symptoms and can cause pain. And the pain can be prolonged. The typical way that patients describe these pains are tingling, numbness, feeling hot and cold, sometimes hot water dripping on the leg. And you can usually find that the sensation to one of these areas is altered. This is also a risk factor for developing more pain-associated problems, such as complex regional pain syndrome, and also having prolonged symptoms with the ankle. I think diagnosing these is really important because the symptoms that the patients experience are not very easily categorized into the mechanical things which they expect to be going wrong with them. And this disparity between what they feel mechanically and the pain that troubles them can then lead to them developing chronic pain conditions. So actually telling the patients that there is a nerve injury which is associated with their ankle sprain has in itself quite dramatic therapeutic value. The other issues that we have to be aware of are injuries to the articular surface of the talus and the tibial plafond. So here we have an MRI scan of quite a large osteochondral lesions. And I usually have quite a low threshold for assessing patients with an MRI scan, really to make sure that we pick up occult injuries very early on in the diagnostic pathway. And once you have picked them up, you can then predict slightly more accurately how the rehabilitation can unfold. Now, what do we do about treatment? A lot of what I'm going to say is actually based on the consensus statement, and I'm very happy to share the reference with you with regards to the various things to do with ankle sprains, the typical history, the typical diagnostics that we need to use and what we aim to glean from each of those, which I've explained to you already, and then thinking about what treatment algorithms and what treatment pathways work best for the patients. So just to give you a very quick synopsis of the three headlines that they mention in their abstract, is that the non-steroidal anti-inflammatories, it's a regular thing. You know, everyone is told you've got an injury, do take non-steroidals. They are very good for pain, particularly in the acute phase. The issue is that they do have complications. Your patients can have gastric complications, renal complications. In patients who have asthma, they may trigger an asthma attack. And there is some evidence, particularly from basic science studies, that you may impede the healing process by applying non-steroidal anti-inflammatories for a prolonged period of time. Particularly in my work with non-unions, I know that non-steroidals are associated with slower rates of healing of bones, and especially in fractures. Supervised exercise-based programs, essentially physiotherapy and functional rehabilitation, is actually what is required in the vast majority of cases to regain function and regain joint stability. Surgery is absolutely reserved for circumstances where there is failure of rehabilitation and the patient still has a functional deficit which is interfering with quality of life. So I'm going to delve deeper into what they discussed and tell you a little bit about the things that they've come up with. R.I.C.E. Now, with resting, icing, elevating, now this has been shown that it works in reducing swelling, but it doesn't really have a great deal more to offer. I do advise it to all of my patients. A lot of patients find that it reduces pain and it's good for comfort in the immediate post-injury phase, but the evidence for it is not dramatic. Non-steroidal anti-inflammatories, as we said, they are good in reducing some of the swelling. They are good in reducing pain, but they don't really have a great deal more to offer. And they're good in the acute phase. Complications, interestingly, not dramatically different to placebos, but they have well-established complications in patient groups that have comorbidities. So it's crucial that you take a history from your patients before you decide to offer them these anti-inflammatories. With regards to splinting, immobilization is actually very good for pain, and I'm a big fan of it, particularly in the first few days after the injury, and I'll come to describe that a little bit more later on. With regards to other things, such as improvement in the outcome measures, return to work, return to normal activity, functional support, and I'll come to what that looks like in a moment as well. Also, functional support, not immobilization, such as stirrup ankle supports, are much better for returning to sporting activities. With regards to physiotherapy, it is the thing to do to infer both the objective and subjective stability to these ankles as they recover. Also, return to sports. Individuals who want to return to sports, physiotherapy is absolutely the right way to go. So what do I do? And I'm going to talk you through my algorithm for treating ankle instability. So first of all, it is incredibly important to exclude other pathologies because some of them are surgical and they need to be treated that way. We need to make sure that they don't have fractures. We need to make sure that there are no tendon injuries or tendon ruptures. These are very important. In fact, in some slightly older individuals, occasionally Achilles tendon ruptures are mistaken for ankle sprains and are not treated very well. So exclude other pathologies. I immobilize for 7 to 14 days, and this is very much dependent on the individual patients. There are some, because they've had a slightly more severe injury, they've got more of the ligaments that have been injured, they may have a lateral ligament, their medial ligament injury as well. They need to be stabilized for a slightly longer period of time. And I advise R.I.C.E. And I'll tell you what my R.I.C.E. protocol essentially is. So resting, you limit weight bearing, give them crutches if necessary. Some individuals find it very painful. The ankle brace helps with the swelling, and it helps with stability, and it allows patients to ambulate and be self-sufficient. When you advise them to have ice, I'm sure you know this, it is important to not have it directly on the skin, and it needs to be a little while on, a little while off, 15 to 20 minutes on, and then up to an hour off. Not to, again, very important to avoid having skin problems and frostbite from that. Compression is good for control of swelling, and some patients have abnormal sensations in the skin and they find the swelling painful. So in fact, compression bandages can be very helpful in this period. Elevation is also very important for reducing the swelling. One of the things is that if the swelling is not managed at the outset, and the patient is not instructed to keep the leg elevated, the swelling can then take much longer to settle down around the other end. So early management of swelling means that swelling actually lasts for a slightly less period of time. At about a week to 2 weeks down the line, I convert them to a stirrup ankle support, and here is a typical example, the Aircast A60. You can see that it's got two stirrups. It's got a stirrup so that you've got hard bits on either medial and lateral side of the ankle, but it allows plantar and dorsiflexion. I then start early functional rehabilitation. There are a very small group that fail this. This could be anything between 5 to 15% of individuals, depending on the severity of the injury and their ability to carry on with the rehabilitation. Of these, I then offer them, so this is in the chronic situation, which is where I find I do almost all of my ankle ligament reconstructions. that you have an examination under anesthesia, arthroscopy of the ankle, and then the reconstruction of the appropriate ligament. Of those who actually go on to reach this stage, the vast majority of them tend to have other problems. They have synovitis and impinging lesions maybe. There may be association with bone spurs. Many of them may have osteochondral lesions and also other ligament injuries. One thing I haven't mentioned here is syndesmotic injuries, and there is a large association with syndesmotic injuries, particularly if they have deltoid ligament injuries as well. For the type of repair that I do an anatomic ligament repair. If the quality of the ligament is good, you can do a direct repair, but additional internal brace and additional augmenting techniques are required if the quality of the ligament is poor. The individual that you're operating on may be unreliable. They have general laxity, and particularly in elite athletes, because that allows for much more rapid rehabilitation. I explore the peroneal tendons through the same incision because you're there, and I address the pathologies to do with the peroneal tendons at the same time. I always share also the goals of rehabilitation with the patients. You have to have a sort of a light at the end of the tunnel to see what it is that they're aiming at. They need to be bearing load early on. They need to start range of movement exercises, again, very early on, strength training, and then proprioception and balance rehabilitation. At the same time, I get them to work on their core strength and core stability and other areas that need rehabilitating. Failure of rehabilitation, failure of these goals leads to somewhere between 3 to 30% of individuals to develop chronic symptoms. And even in those patients who develop chronic symptoms, you have to cycle back through the physiotherapy protocols, give them another round of physiotherapy, and even of those group, I think another 70% or so go on to have a good functional outcome. So really, the take-home message from my talk is twofold. Make sure that you understand the pathology of your patient so that you diagnose all of the lesions that are associated with this injury, and stress upon them the benefits of functional rehabilitation before you think about surgery. Thank you very much, and thank you for listening. I can see that we've got, so I've got one question from Mel. Internal brace for patients with hypermobility of the ankle. Yes, because even patients who have hypermobility, they really can have very mechanically unstable ankles. And when they have these mechanically unstable ankles, even the most amount of functional rehabilitation may not provide them with the strength and the stability that they need. And because their own tissues are not of good enough quality, the internal brace is then the thing to augment it with. Right, well, thank you very much. I'm going to hand you over to my good friend, Tom Hester, who's going to talk to us about heel pain. Take it away, Tom. Thank you.
Cheers. I'll just start sharing the screen. I was just typing an answer to that question, actually, Nima, about the use of internal brace in hypermobility. I think that's a great question, great indication for it as well.
That's right, yeah.
Okay, so for those of you who sort of missed the start, my name's Tom Hester. I'm a fellowship-trained foot and ankle surgeon, currently a consultant at University Hospital Lewisham, but I'm moving to King's College Hospital in the next few weeks. I've got no relevant disclosures. So what I'm hoping to do is just go through an overview of heel pain, go through the differential, a little bit more in depth for the pathophysiology, as that can be a bit of a sticking point. and then sort of focus on plantar fasciitis and the Achilles tendinopathy. Trying to make it relevant to COVID, as there is a few things coming out of this sort of current unusual time that are relevant to heel pain. Typically, heel pain sort of elicits this type of response. There's no fancy videos, slow motion sequences, or bones sticking out through the skin to get people excited with. But the size of the problem is massive. 1 in 10 people will experience heel pain, and up to 40% of foot and ankle clinics are filled with it. It's a big problem. And it's going to come even more so. This is a great graph from Garmin, showing sort of around that lockdown period, March the 9th, and it shows the activity levels in various countries across Europe. UK is the orange one, and you can see that from lockdown, there's around a 50% increase in people out running during the, to get their daily exercise and get out of the house a little bit. So I think the problem is only going to get bigger with COVID as people start to get a bit more active, and certainly those people who aren't being as active. So a quick overview of the anatomy, sort of supplementing what Nima's been through. This is a schematic from the medial side. The tarsal tunnel, so that flexor retinaculum, has been removed sort of across here, and you can see the underlying long flexors there. But most importantly, just to remember where the tib post tendon is, and the subsequent branches down to the lateral and medial calcaneal branches there. On the lateral side, just bringing your attention to the Achilles insertion to around this Haglund's deformity, and then the plantaris tendon on that medial side. And I'll go through that in a little bit more depth, particularly with relation to midsubstance Achilles tendinopathy, and then the sural nerve and your peroneal tendons coming down there. From the sole of the foot, this one's got that tarsal tunnel, so the flexor retinaculum is intact there, so you can see where the tarsal tunnel is and the nerves emerging from underneath it. And then the plantar fascia, particularly that main thick band on the medial side, and then the sort of lesser two central and lateral bands. Okay, so going through the etiology, sort of 3 main groups. You've got one of the biggest issues is sort of determining that underlying cause. You've got raised BMI patients, then you've got the raised BMI, which has been shown to be a contributing factor now in lots and lots of studies. And then you've also got the very active patients, typically runners, and I suspect this is what we may see. Sorry, the lights have gone off in this sort of post-COVID time. And then you've got, and they also overpronating, and then it's sort of all brought together by a tight gastrocnemius or a tight posterior cord, sort of causing that imbalance in the mechanobiology. Looking a little bit further in depth, sort of at the on a microscopic level, is this Fu's model of sort of tendinopathy, but it can also be applied to sort of fasciitis. And he broke it down nicely into 3 phases, which really consolidates the idea of the intrinsic and extrinsic factors, which I'll go through a little bit later. And what this shows is that tissue overload is the key driver. And tendinopathy is an active process. And it's the mechanobiology, coming back to that tight posterior cord, that sort of drives the inflammatory response. And the difficulty is we need inflammation for healing, but how do we prevent it progressing into that sort of fibrosis, apoptosis, and that irreversible harmful changes? And it's those are the issues, and what makes sort of heel pain a very difficult problem to treat. On a cellular level, this is a great little study. They looked at 50 patients who were having their heel spurs removed with a MIS burr, but they took samples at the same time, and it showed that rather than a acute inflammation, it's actually a degenerative fasciosis. So it's not a true fasciitis of the plantar fascia. Looking at the Achilles, the mid portion of the Achilles is the most commonly affected and accounts for around 55 to 65% of Achilles tendon related pathologies. And that's sort of followed by the insertional tendinopathy, accounting for around 20 to 25%. When you look at the midsubstance tendinopathies, the role of plantaris is often being implicated, and that's sort of via a number of mechanisms. You've got a differential in mechanical forces between that little plantaris tendon and the Achilles, and that creates shear, leading to that fusiform swelling. A variation in the plantaris insertion also sort of determines the interaction between plantaris and the Achilles, and also if that plantaris inserts into the tarsal tunnel, it can also mimic then a sort of tarsal tunnel syndrome as well. There's also a differential in the viscoelasticity between plantaris and the Achilles, and therefore that leads to strain, and then leads to midsubstance tendinopathy and a subsequent increase in the glycosaminoglycans, and that's what gives you that actual swelling of the tendon. So differential diagnosis of heel pain. I broadly split it into three categories: sort of soft tissue, but excluding the nerves, bone, and then the neurological component. On the soft tissue, obviously the plantar fasciitis, the Achilles, as I mentioned, but it's important to remember, as Nima talked about in his instability talk, is that the rupture, particularly those chronic ruptures, can also present with that sort of vague heel pain, and often can be confused with midsubstance Achilles tendinopathy, where in fact it's actually just the scar tissue of a previous rupture. Kegis fat pad inflammation, fat pad atrophy, which is a very difficult problem to treat, even in combination with plastic surgeons and common fat pad transfer, and fibromatosis. Particularly in new runners, important to rule out stress fractures, Haglund deformities, and then the sort of less common ones, infection, tumour, and Paget's. And then in the neurological ones, tarsal tunnel syndrome, which I'll talk about in a little bit, Baxter's neuropathy, and then the referred sort of sciatica type pains coming from the back. So when you're taking a history, I try and split it into, sort of going back to a Fu's model, looking at the intrinsic and extrinsic factors. Everyone looked at age and gender. Previous history is really important. Has there been a precipitating event? Medical history, bear in mind that a heel pain can be a manifestation of a systemic cause, and I'll mention that more in my next slide. And the biomechanics, is there an underlying spasticity that could be causing issues? Extrinsic factors, they started a new sport, new way of running, changed their footwear, and medications. Everyone associates a quinolone, particularly ciprofloxacin, with tendon ruptures, but actually it's also very important and is a real cause of tendinopathies as well. So it's worth going through those in your history. This is a nice little mnemonic from Paul Kerwin. He's a physio currently studying, working for his PhD. It was initially designed for knees, but I think works really well for heel pain as well. But basically, it's sort of there to rule out the more systemic, so the spondyloarthropathies or the inflammatory arthropathies, just to make sure you're not missing anything more systemic. And very commonly, patients come to you sort of labeled with plantar fasciitis, and it's very easy just to get into that sort of that way of thinking. But it's worthwhile just making sure you're not missing anything. And likewise for those first-time presenters, young patients, just to ensure you're not missing a systemic problem. So going on to the examination, just some specific points. The plantar fascia, common pain is on that medial calcaneal spur. But don't forget that central band, so where the orange oval is on the diagram, is also a common site for plantar fasciitis. Calcaneal squeeze test for stress fractures, and then percussion or Tinel's test over the tarsal tunnel and a tibial nerve for tarsal tunnel syndrome. So imaging. Whilst the role of imaging may be initially limited, I think a lot of the patients, by the time they reach us, and yourselves more than likely, have gone on the internet, they've sort of researched it. They tend to be that sort of self-selecting group who have tried to improve their symptoms sort of in their own way, and so whilst the diagnosis is predominantly clinical, I think if a patient is failing to progress as expected, or there's any doubt, then I'd start off with a weight-bearing plain radiograph, and then go up from there. I think this example, you can see the calcification of the insertion of the Achilles. There's a small Haglund's deformity, and then you've got that medial calcaneal spur where the plantar fascia inserts onto the calcaneal. This may not be pathognomonic of plantar fasciitis, but certainly it can support your diagnosis, particularly if your examination findings confirm that. Next level of imaging, there's a lot of debate, or I think there is a really good role for ultrasound, particularly dynamic ultrasound, and that can show you nicely the relationship of plantaris with the Achilles. But my preference is for MRI scanning. These are some fat-saturated T1 sequences, and also there's a T2 image there as well. And you can see here on the bottom left hand, there's some inflammation around the Khakha's fat pad and some associated edema within the Achilles tendon and the Haglund's here. And then on the top right, you can see that calcification into the tendon there, on a classic insertional Achilles tendinopathy, and then an increased uptake of signal around the plantar fascia insertion there. So treatment. I think one of the reasons why heel pain is so interesting is that the treatment is always evolving. And it may be that we've still got a long way to go, I think, to successfully manage this. And if you just look at this article from JFAS, it showed that over 25% of all foot and ankle articles in 5 high-impact journals were just looking at heel pain. So that gives you an idea of the sort of problem in the research, and that that's out of all the foot and ankle pathologies, and particularly ankle replacements, which is a huge expanding area. 25% are still all related to heel pain. So what are your options and a possible algorithm? Physiotherapy makes up the bulk, the mainstay. This now it's rather than a stepwise process. I think now people are going more towards a combination of treatments, so physiotherapy, orthotics, injections. I'll talk a bit more about that in a minute, and then a role for surgery and when that comes in. So this rather busy slide is really just to demonstrate that there are lots of papers out there supporting stretching and physiotherapy. And the consensus is really that it just overwhelmingly works. Pierpont et al. Showed in 50 patients that just 4 weeks of combined plantar fasciitis and tendo Achilles stretches significantly improved morning pain and medial calcaneal tenderness. So it's really important to try and get patients to persevere with it, and a lot of the time, certainly in my clinics, I find that people feel that you're holding something back and you're just going through the motions by giving them physio, but the evidence is out there. It overwhelmingly works, providing you can get buy-in from the patients. The reason that the sort of stretches work is because they improve the tendon length, load, and speed. If the tendon is pre-stretched, its resting length is increased, and there will be less strain on that tendon during the movement. By progressively increasing the load exerted on the tendon, there should be a resultant increase in the inherent strength of the tendon, and by increasing the speed of that contraction, a greater force will be developed, and all of this can help improve their symptoms. There's differences in the makeup of the stretching regimes, and with variation around the sort of classic Alfredson protocol of eccentric stretches. Head et al. In this nice systematic review, looked at different types of stretching program in midsubstance tendinopathy, and found there was no superiority on the differences in stretches. But what they did say is that by tailoring the prescriptions of the stretches can really help. So whilst Alfredson, the protocol there is a really nice sort of base to start, if you tailor that, particularly the sort of number of repetitions and the maximal dorsiflexion, can really help help improve compliance. And that's particularly important for the insertional Achilles tendinopathy, who I think do struggle, particularly with the initial eccentric or maximum dorsiflexion to start off with. But if you can go through some gradual increases, then that can be beneficial over time. Night splints, again, shown time and time again to help. Poor patient compliance is often demonstrated, and I see that a lot in my own practice. So, educating the patients is about its success is a real must. Mark Powell carried out a nice prospective randomized controlled trial, albeit with small numbers, but found nearly a 20% loss of patients due to poor compliance. But it found that if you could stick to it just for, again, 1 month, compared to those who didn't use night splints, you had significant improvements, up to 90% patient satisfaction and functional outcomes, which is fantastic. If that's combined with a simple orthotic, such as a small heel raise, then that's been shown to improve outcomes even further. And there's a lovely JFAS article by Lance Barry demonstrating that. Taping, it's long talked about. It's seen, I think, or I've certainly seen to see a bit more of a resurgence. Even though, that article there's from 2006, but I think the popularity of kinesiology taping in footballers is showing that people are becoming a bit more interested in it. Highland did a nice, just a little prospective randomized controlled trial. Actually, it was a nice crossover trial as well. 41 patients, and they showed significant improvement in pain scores, and that was just with a week's worth of taping. And obviously, the upside to taping is there's very little, there's little to any complication rate. You might find a small irritation to the actual adhesive, but Highland didn't report that in any of his series, and I haven't actually seen that documented. Shockwave therapy is, I feel, a really useful adjunct. There are some nice guidelines, but the one I put up there is for Achilles, but they are also there for plantar fasciitis. At the moment, the ones published in 2016, they don't give any clear recommendation for it yet. They just say further evidence is needed. But I think that there are some reviews out there and some randomized controlled trials showing that it does work, certainly in the short term. My preference is for radial, sort of low intensity shockwave therapy. I think that gives you the best patient compliance and the sort of best results. There's a growing move towards the high intensity radial, but from my experience, I think patients really do struggle to tolerate that. And then you lose that compliance. You really need, certainly for the low energy, the 3 to 5 sessions with a sort of week interval. And I think that does give you a good outcome. So injectables, obviously there was a slight change in regard to corticosteroids yesterday at the number 10 daily update. However, as of going live on this webinar today, the guidance is still that the use of corticosteroids is basically on hold. We should discuss it on a case-by-case basis, and we should certainly avoid it in the high-risk patients. And certainly, most, I think all of us wouldn't inject a asymptomatic or ill patient anyway with a steroid, and we would wait for them to be quiescent. And that's pretty much what the combined guidelines are saying at present. Although with yesterday's news about steroid use, certainly systemic steroid use, this may change. But it does bring up a potential useful adjunct to injectables, and that are the biologicals. PRP versus steroids in this systematic review of the meta-analysis showed that certainly in the short term, PRP was more beneficial than steroid injection for chronic plantar fasciitis, and so it considered safe. So it may be a good adjunct or a good alternative in these sort of challenging times. So what is the role for surgery? I think the insertional Achilles tendinopathy and Haglund's deformities, certainly in patients who have undergone full conservative measures. There's a pretty good surgical option, which is my preferred preference: central incision, so an open approach, and removal of the apoptotic tissue and that calcific spur, and then suturing that back down with a Achilles speed bridge. There is a role for MIS, certainly if there is no calcific infiltration or no obvious damage to the insertion of the Achilles on the MRI scan. And this is supported with the evidence. James Nunley did this nice study with a minimum of a 7-year follow-up and showed 96% patient satisfaction and 95% pain-free. So that's a good, reliable surgery for the insertional inner haglets. Recovery-wise, it's a day case procedure. I get them into a boot in mid-equinus for a couple of weeks. They're weight-bearing at that point, but then at 2 weeks, get them plantigrade, and they can start physio. Limited dorsiflexion for up to 4 weeks, and then aim for a return to sport around 3 to 4 months. Midsubstance tendinopathies. Nick Van Dyke looked at sort of surgical treatment of the mid portion. He found high patient satisfaction rates with open debridement and excision of the plantaris tendon. My preference is for an open procedure, not quite as large as these photos, enough so I can see and then explore the tendon, look for any any necrotic areas or damage to the Achilles tendon itself, and then excise a small section of the plantaris. But he did. Van Dyke did find that there was a reasonable complication rate of around 10 to 15%. So it's not a trouble-free procedure. That said, if they've exhausted conservative measures, you've explained the risks and benefits, then you can get some good outcomes. Gains, day case, get them into a boot, this time straight weight plantigrade, weight bearers tolerated, and then dependent on the level of tendon involvement, get them starting a full eccentric program at the 2-week mark. And that's what that little asterisk is there for. Just like to see what the tendon looks like on table. Again, with an aim to return to sport around that 3 to 4 month mark. Recalcitrant plantar fasciitis is often a difficult problem. There is a growing body of evidence that by doing a medial headed gastroc release has good results, and this is my personal preference. It's a nice procedure. I think in the right patients they do very well. Gamba from Barcelona had patient satisfactions at 86% at a year's follow-up, and those were patients who'd had a minimum of 9 months worth of plantar fasciitis. So you've really got to exhaust the conservative measures, but in a select group of patients this does very well. You can also look at removing the heel spur, so that sort of plantar heel spur with an MIS spur as well. And I know David Redfern's sort of championing that, and he's getting reasonable results. My personal preference is the medial headed gastroc release. Again, day case procedure, straight away into normal footwear this time rather than a boot. Weight bearers tolerated. Night splinting is really important just to maintain the gains you get from that gastroc release. And then eccentric physio stretches as soon as the wound is healed. And again, return to sport at around the 3 to 4 month mark. So, take-home messages. I think it's always important to confirm the diagnosis. Make sure you're just not missing anything, and also to remember the whole patient. And try and make sure you're just not following on the label that they've been given elsewhere. Exhaust non-operative options first, and these should be done in parallel, not just in serial. So combining all the modalities at once can really give you excellent conservative measures beforehand. Once you've exhausted all these options, then there may be a role for surgery at around the 6 to 12 month mark. Okay, and that's it for me. So Thank you very much. This slide just tells you what is coming up. And I'll just have a look, see if there's any questions that Nima hasn't healed.
It's a great talk. Thank you very much. We've got a good question. What about retrocalcaneal bursitis? What's your thoughts and your algorithm for dealing with that?
So I think the retrocalcaneal bursitis is actually one of the few that you can inject safely with steroid injections, rather than sort of mid-substance tendinopathies. In my opinion, I'd still only do one, maybe two injections. What you don't want to see is that. I'm sure we've all seen it, that those pictures of really wasted Achilles, where all the subcutaneous fat has disappeared. But I think a single injection along with conservative measures is good. If not, then there's a role for excision of the Haglund's deformity with a little MIS burr, or arthroscopic debridement, sorry.
And just one thing before we close as well. I mean, one of the things that I get asked quite a lot is patients have put up with symptoms usually of this heel pain for a little while, and what do you tend to tell them of how long things will take before they can start seeing some improvement?
I mean, with regards to conservative measures, sorry, Nima, is that what you said?
Yeah. So before, how long should I carry on with physiotherapy? Before?
Yeah. Well, I mean, I think a few of those papers I mentioned there, they're showing if you can get compliance and actually carry out the sort of prescription or the physio instructions at 4 weeks with good compliance, you should be able to see some improvement.
Okay.
But it does. But it's the compliance, and I think that's it's the same with orthotics. Really trying to get patients to comply, and it is very difficult. I mean, night splinting. I don't know whether you've tried them, or people in the participants have tried them. They are a bit cumbersome. You roll over, they bang the other side, and they can be a bit of a nightmare. But having had plantar fasciitis myself, they do work, and I think they're fantastic. Well, there's a couple of other questions are coming in now. Is there any evidence that walking barefoot at home is good for building up and maintaining foot strength health? And what are your thoughts on long-term impact of footwear and foot pain health? And what constitutes good supportive footwear in an otherwise normal foot? Well, this is an excellent question. I think it is, but and I could talk about this forever. There's that great, I don't know if you've read that book, I think it's Born to Run, and there's a whole section that basically dedicated on this, and then I did a lot of reading around that, because there's a lot of running teams that basically switch from wearing these very accommodative, Nike, manufactured trainers, there are other brands out there, to what they would deem to support the foot, but actually, as soon as you start, similar to a cast and other sort of splints, or sort of static splints, when you start supporting things and you start losing muscle bulk, and then you get muscle wasting, and then you start affecting the architecture, and then you start getting into a sort of downward spiral. And I think that's where the sort of free running, barefoot running trends have really come from, is that actually by going back to sort of Mother Nature, or going back to sort of plain physiology, you can really work on improving those intrinsic muscles in the foot, and that can actually, then that helps your posture. It improves the way you run. You run like a tripod rather than a heel strike, and then that improves your biomechanics. And I think that sort of long term is excellent for foot health. So what constitutes a good supportive footwear? I think obviously the best support is your own support, and something that you find comfortable. There are times where we need to get the inflammation to settle down, and that's when wear orthotics and like medial posting and things to help with tib post tendinopathies. That's where they come in, and so it's very much dependent on the patient really as to what their symptoms are and what you want to achieve. I think a normal physiological foot, though, barefoot running or barefoot walking is ideal, and that's like walking on sand is fantastic. Sorry, Nima, have you got anything to add to that one?
No, I totally agree. I think that the key thing that you mentioned is that you've got to get the right diagnosis and try and see what it is that you're doing. I mean, I find that with regards to when there are any issues and we're worried about what to do with footwear, I have very low threshold of sending patients to podiatrists that I work with regularly for them to have a look, because they look at it with a very different eye. But I agree with what you say.
Yeah, I mean, there's definitely a role for for the gait analysis labs, and like you say, some of the podiatrists and well, a lot of the physios and ourselves can get a lot of information out of that, and that can really help with the sort of with long-term management, or they guide you with your footwear. Everyone's always trying to stamp out an overpronating foot, and pronation is overpronation is associated with heel pain as well. So yeah, it's some help.
And very quickly, we've got 2 more questions, and I think we'll attend to these and then wrap things up. The role of prototherapy in Achilles tendinopathy. What are your thoughts on that?
I mean, I don't have much experience or use it much. Do you use it much, Nima?
I don't use it a great deal either. My usual go-to is that a bit of hydrodilatation some time ago, and again, I'm a fan of biologics, PRP in particular. Again, for some of the reasons that you've mentioned, when you've got steroids into close to pathological tendons, the risks of rupture are high, and also you reduce the ability of the soft tissues around there should you want to go back in and operate on them to heal at a later date. So I think that there is a role. You've got to talk to someone who knows a bit more about it. My personal thing is PRP for these.
Yeah, I agree. And then besides imaging, how can you, so clinically, I mean, it's difficult, and I think that retrocalcaneal bursitis or that Khakha's fat pad inflammation, they tend to have pain a little bit more anteriorly to the tendon itself, rather than the insertional pain, which is right down to the insertion of the Achilles, or you can feel that that bump, the bump where if they're calcified. But yeah, it's a little bit more anterior, I would say. But I agree. They're very similar in clinical findings, and it may be hard to then to avoid further imaging if that's what you're trying to do. But yeah,
agreed. Brilliant. Well, I think what's left to say is to say thank you very much for all of the attendees, and thank you, Tom. The series for our webinars from the orthopedic specialist, the next one is on the 1st of July. We really look forward to all of you joining us then. And also, don't forget, we're going to send you a questionnaire, fill it out, send it back to us. We've got CPD points for you from the Royal College of Surgeons.
Thanks, Tom and Nima. Great job.